I'm Rhonda Hodnett, the Assistant Secretary of the Division of Child Welfare at DCFS. In this video, you will hear about a screening instrument used to help identify trauma-related problems in children and teenagers. You will also learn about the best ways to help kids with those problems. With better methods to detect the impact of trauma and training to provide evidence-based treatment for traumatic stress, we can make a tremendous impact in the lives of these children.
The TBH is part of a process to understand the prevalence and impact of trauma, use standardized screens to detect trauma and behavioral and emotional problems, work with community clinicians to provide evidence-based treatment.
When I was about 2 years old, I was in the custody of my biological mother. The major event that occurred in her house was that she had decided to place me in a tub of hot scalding water. I suffered third-degree burns of 43% of my body. They placed me in the custody of foster care. About a year and a half into it, I met my nurse, Lenore, and she was the one who decided to take me in her home, and I became her son, and I've been her son since then. I haven't had any type of therapy when I was a younger kid. I only had maybe 2 or 3 therapy sessions when I was like 12, but it was more regarding like burns and dealing with like how to deal with people regarding my burns, but not really my trauma as a child.
By implementing these methods and trainings, we expect to more accurately identify children who have experienced trauma and need treatment. We also expect that these children will get more effective treatment that will result in better long-term outcomes. This video is also intended for the many stakeholders who are part of the child welfare system. You may be a foster parent, teacher, therapist, doctor, or lawyer. It's important that every key player in these children's lives understands trauma and its impact.
What is trauma? In terms of mental health, trauma has a specific definition. Trauma is defined as an experience that is perceived as life-threatening or a severe threat to a person's body. These include sexual abuse, physical abuse, witnessing domestic violence, motor vehicle collisions, burns, dog bites, disasters, and medical procedures. Trauma is common. In one of the largest studies ever conducted in the United States, researchers from Duke University found that more than 2/3 of all children had experienced at least one life-threatening traumatic event by the age of 16 years. And of those who experienced at least one trauma, 38% had experienced more than one trauma. This is relevant when screening for trauma because it's important to ask about all traumatic experiences.
In the first month after life-threatening trauma, nearly 100% of people will have symptoms that look like post-traumatic stress disorder, or PTSD. We have really good research, however, that shows that most people are resilient. After about 1 month or so, these symptoms go away for about 70% of people, and they have no enduring emotional problems afterwards. The group we're concerned about is the 30% who, for whatever reasons, are vulnerable to develop PTSD. These individuals have tremendous problems. They have severe impairments in their ability to function, and they often suffer in silence because they want to avoid remembering, and nobody asks them the right questions to get them the help they need.
On the outside, a lot of people see me as this bright, happy kid, and a lot of times when I tell them about some of the things that happened to me, because a lot of times I'm willing to tell you what happened, but I won't tell you how I feel about it, because a lot of times I don't think I can handle if I'm truly honest with people about how I feel about it. So I'll just tell them like I'm cool with it now or something like that. I'll just like throw it off.
In the official definition of PTSD, there are 20 possible symptoms. These are divided into 4 types. The first type consists of 5 re-experiencing symptoms: intrusive and distressing recollections of the event, flashbacks and freezing, nightmares, psychological distress at reminders, physiological distress at reminders. The second type is 2 avoidance symptoms: avoidance of thoughts, feelings, or conversations associated with the event, avoidance of people, places, or things associated with the event. The third type is 7 symptoms of negative thoughts and moods: inability to recall important features of the traumatic event, distorted blaming of oneself or others for what happened, persistent negative emotional state, restricted range of affect, loss of interest in usual activities, negative beliefs about oneself or the world, detachment or estrangement from others. The fourth type is 6 increased arousal symptoms, self-destructive or reckless behavior, difficulty concentrating, difficulty sleeping, irritability or outbursts of anger, exaggerated startle response, hypervigilance,
A diagnosis of PTSD is made by a licensed clinician. However, before a child sees a clinician, we can gain information about PTSD reactions and their severity that will be helpful for treatment. The best way to measure the severity of PTSD reactions is to rate the severity of each symptom on a number scale, and then add up these numbers for a single total score.
In the next part, we will introduce you to the screening measures, the Trauma and Behavioral Health Screen, or TBH. You may be familiar with rating symptoms on a checklist already. Usually, checklists take the form of rating a symptom on 4 choices, such as 0, it happens none; 1, it happens a little or is mildly distressing; 2, it happens often or is medium distressing; 3, it happens a lot or is severely distressing. The 0s, 1s, 2s, or 3s are added up for each symptom to get a total score. There are many of these types of checklists published. Some of them assess only the 20 symptoms that are used in the diagnosis of PTSD. Some of them ask about other types of symptoms.
The TBH, or Trauma and Behavioral Health Screen, is a checklist that has replaced the BH1 assessment previously used in the DCFS system. Its emphasis is on covering all possible types of traumatic events.
The TBH covers 15 PTSD items, since PTSD is the core psychological issue for traumatized children. Finally, it also covers co-occurring problems like depression, anxiety, oppositional defiant disorder, and ADHD. This is because PTSD is actually just the core issue. When people have the diagnosis of PTSD, about 80% of the time, they have at least one other co-occurring or comorbid psychiatric diagnosis. Some of the time, these comorbid disorders were there before the traumas, and some of the time, these comorbid disorders developed after the trauma, the same time as PTSD developed. That's why it's important to cover all the possibilities, and the TBH is designed to do just that.
As a caseworker, you should hand out the TBH to every child in your caseload. It should be completed for every new case and then re-administered every 6 months to each child. The TBH is comprised of 56 items and is designed to be self-administered. There are 2 versions, one for caregivers and one for 7 to 18-year-olds to fill out themselves. When a child is under the age of 7, only the caregiver will fill out the TBH. When the child is age 7 or older, they will fill out the child version of the assessment, and their caregiver will also fill out the caregiver version. We will be collecting both forms. Sometimes a 7 or 8-year-old will not be able to fill out the TBH on their own. You can use your own judgment on a case-by-case basis to see what works best with each child.
If a parent or child has trouble reading or understanding the questions, you may need to walk them through the TBH yourself. It's important to be familiar with the measure in advance so you can anticipate potential questions. To administer the screening instrument sensitively, be sure to speak as calmly and matter-of-factly as possible. Remember that talking about their trauma is often difficult for people. Sometimes you might get asked what counts as trauma. Remember that trauma is something that is perceived as a life-threatening event. It does not include things like chronic neglect, divorce, or watching violence on TV.
The next thing I'd like to do is have you fill out a questionnaire that we give to everybody. This will just help me learn some more ways that we can help your child. It includes some questions that covers traumatic events, so it might be kind of difficult to answer, but I'd like you to just try your best to answer as many as you can. The first page is about trauma events. Mark in this column if the event has ever happened, if you know how old he was the first time it happened, the last time it happened, and about how many times it happened. You can write that in here. The second page is about symptoms of post-traumatic stress. And the last page is about other things like depression and disruptive behaviors. So for each question, just try and choose the answer that you think fits him the best. I'm gonna work on some other paperwork while you're doing this, but let me know if you have any questions.
Do the same thing when you administer the screening instrument to 7 to 18-year-olds. By the time you administer the TBH, you will have spent some time getting to know the children in your caseload. You may know which children will need help reading and understanding the questions.
If children become upset while filling this out, empathize and ask them if they'd like to continue or not. Remember, some distress from reminders of traumas is part of PTSD. If being reminded of their traumas by these questions is upsetting, it's likely that they have these upsetting reminders much of the time. It's important to remember that you're not causing new memories. Most children understand that you're trying to help them.
Any distress the child experiences should be temporary. If distress continues, remove the questionnaire and do things you would normally do to comfort the child. Remind the child or their caregivers that they have your office number to call if they need assistance after you leave. Please be sure to take a moment to check the TBH thoroughly before ending your visit with the client to be sure that it is complete.
Check to see that they have answered every question on the checklist. If a question has not been answered, point it out to them. Also, sometimes people will circle 2 answers for a question. If this occurs, you should use the higher of the 2 scores when entering the results in the database. You should also check over every answer to make sure that no red flags have been raised that could be cause for immediate attention. Also, note that the last 11 questions on the TBH are related to dangerous behaviors, psychosis, substance abuse, autism, and preschool conditions.
If any of those last 11 questions have been answered yes, that is probably cause for follow-up questions and for a referral if the child is not already in treatment. If follow-up questions indicate that a child is unsafe, the caseworker should consult with their supervisor regarding the agency's protocol for crisis intervention.
Asking these questions can be difficult, but it is very important. The effects of psychological trauma have been recognized for decades. Professionals of all types have been silent for too long by not asking children about these issues. Children who have been through traumatic experiences usually are not going to volunteer to talk about these things because avoidance of reminders is actually part of the syndrome. In my experience with over 500 children of all ages who have PTSD, most children appreciate that someone asks them about their problems.
Most of the time, you can tell pretty quickly by watching someone whether they have hyperactivity or depression. You can't tell who has PTSD just by looking at them. Their symptoms are not obvious, like depression and hyperactivity. Their scars are hidden. This makes trauma-related problems harder to detect and is one of the big reasons we need this screening procedure.
How is PTSD different from other problems? First, many of the symptoms are internal to a person, and we can't see them easily on the outside. For example, avoidance of thoughts or feelings associated with the traumatic events is something that goes on inside a person's head. Children may have nightmares and not tell their caregiver. They can feel distant from loved ones but not know how to verbalize that to their parents. Many of the symptoms are only present when they're confronted by reminders of the traumatic event. If they're successful at staying away from reminders, the symptom may not appear very often. Unlike any other psychological problem, avoidance is part of the disorder of PTSD. People who have experienced trauma don't want to remember what happened to them. They would rather forget what happened. So to ask them to think about their symptoms is to make them remember again. Many children will try to avoid talking about their symptoms because they don't want to remember their traumas.
If children persist to have symptoms for more than 1 month, they need professional counseling. PTSD reactions are not like bad memories or cuts on your skin that go away with time. PTSD does not go away on its own. It takes treatment.
Fortunately, very good treatments exist for PTSD. These include cognitive behavioral therapy, or CBT, eye movement desensitization and reprocessing therapy, or EMDR, and sometimes psychodynamic therapy. The most commonly recommended therapy is CBT. Given the right treatment, the vast majority of people can expect tremendous improvement. Once the client has completely filled out the assessment, you will be entering the scores into a database. When entering the information for older children, you will be recording the responses from the version that the children filled out and the version that the caregivers filled out. At times, it may be possible that the caregivers and the children have reported different answers and have significantly different scores. This is because research shows that children and parents tend to report different kinds of information. The children know more about their internal feelings, whereas the parents are usually more accurate about reporting externalizing behaviors. We don't expect for their scores to match, so the results page will calculate a third score, the joint score. The joint score uses the highest score of either the child or the caregiver. The results page will prompt you if you ought to make a referral.
In order to further document your case planning, you will also notice that when this data is added to FADS, there will be a referral checkbox for you to mark. You should check this every time you make a referral for a client. Just mark yes or no.
Of course, the TBH score is just one piece of information that you have when deciding to make a referral. Even if the score itself does not suggest that a referral is needed, you should always consider all the other information you have when making the best decision for the client.
If the children's score from the TBH indicates that they need referrals for treatment, it would be ideal to refer them to providers who specialize in an evidence-based treatment that has been proven effective for those suffering with PTSD. Research supports the use of CBT as a good method to help children recover from trauma.
Since the information that you will be collecting with the TBH is so valuable, we really want to make sure that it is a tool being shared with the provider when you make a referral. Let clinicians know that you can provide a copy of the TBH to further inform their treatment plan for the child.
The incident happened to me was 15 years ago. If it's still affecting me and my spirits are pretty high most of the time, I think it'd be affecting a lot of kids. If I was to take the TBH today, it will make a huge difference in my life. Any child that needs it, I think it will make a difference in their life. I truly believe that.
For more information, please contact us at dcfs.fostercare.dcfs@la.gov.